So I'd like to introduce our next speaker, Dr. Daniel Hommes. Dr. Hommes is a UCLA gastroenterologist and an innovator and entrepreneur in the field of chronic disease management. For over a decade, he has pioneered different ways to deliver care in a more cost-effective way. At UCLA, he has introduced a model for value-based care delivery, where patient engagement through the introduction of smart apps plays an essential role. Dr. Hommes is a professor of medicine, director of the UCLA Center for Inflammatory Bowel Diseases, and director of quality for the UCLA Division of Digestive Diseases. Please welcome Dr. Hommes to the podium.
It's a pleasure to be here this morning. And thanks to the organizer, I'm super impressed. It's Saturday morning, early morning, and here we are. Thank you so much. So last night I had a plane from Vegas back to LAX because I visit the consumer electronic market in Vegas. And I'm so sorry that I uploaded my presentation last week because it almost changed my whole presentation. It's phenomenal how these innovations currently are happening. Think about virtual reality. You put on virtual reality glasses in a retirement home in a patient, and that patient, while sitting in her chair, can basically walk into the main entrance of UCLA, visit their doctor, have a conversation, look at tests, leave again without hitting the 405. Think about growing, do 3D tissue printing with stem cells, growing out limbs, growing out all sorts of possibilities for organs or defective organs. So I was truly, and then think about the introduction of the flying car yesterday at CES. So think about the health drone, basically getting your patients to the right institute with the right provider. Anyway, we're not there yet, but it's my pleasure to talk a little bit about value-based healthcare and how we can actually build UCLA in our back pocket. Let's first look again at the problem, because that's always a great start. We basically, in the US, we, I think, rank number 28, just above Slovenia in terms of health outcomes. And even getting those health outcomes takes us about $3 trillion per year. 70 to 75% is spent on chronic disease management. So how about that for a start? Then think about a slide that I was able to use from our Chief Financial Officer here at UCLA, which shows you the income and the cost of our health system. And we used to, in earlier years, we used to have more income, more revenues coming from our care, so we'd be able to do all these type of things, but recently those lines crossed. So in my mind, even we're in an RVU-based era, every patient that, and I'm as a provider, I'm incentivized to see a lot of patients, but every patient that walks through our door will cost us money. Okay, that's problem number 2. So basically, what we're faced is, how do we deal with that problem? How can we as providers, seek an opportunity to move out of that fee-for-services? How can we, with Obamacare and everything, a lot of folks pay a lot of money, a lot of premiums for their health plans. It's helping yet. So how do we deal with that? And payers struggle as well because they basically have a problem in containing all costs within their health plans. Another problem that I'm faced with is, and I'm a gastroenterologist, so my passion is Crohn's disease and ulcerative colitis, and as you see on the right-hand side, it's a very costly disease. So we did a little bit of claims analysis, and in my world, we see that most patients that suffer from those 2 inflammatory bowel diseases are not even in the hands of care of well-trained gastroenterologists. Only about 1/3 is in the hands of true specialists. And if we look at guidelines, so 20 years ago in a health symposium like this, I would say, well, guys, we now invented evidence-based medicine 30 years ago, and now we have to adhere to evidence-based medicine guidelines in order to, advance our profession. But even 1/3 of folks, it's around roughly 1/3 of providers only adheres to those guidelines. We have drugs, let's not go into the technical details, but drugs pushed by pharma companies that are really very ineffective, and there's a high use of them still based upon those promotional activities 2 decades ago. We have great drugs, but there's a very expensive drugs, and we see an underutilization of those drugs simply because they're not reimbursed. And there, in my field of chronic disease, inflammatory bowel diseases, about 53% of my patients are on any form of antidepressant or anxiolytic. So that must reflect some form of, something is wrong here. We all think about, during these symposia, about the best way forward. One of the great topics is, moving from symptom-oriented healthcare to prevention-oriented healthcare. That's what we're trying to do with our apps. Using that in the back of your head basically makes us want to move out of urgent care. And because in symptom-oriented care, I would wear a white coat, I would have 3 pagers, and I would have no family life at all. So going to prevention-oriented care, I can start learning. I never played golf, but I'd love to take it up once I get the time. So what you see happening is, and where all those apps come in, is moving from those very overburdened providers into easy-to-use virtual hospitals, whatever, apps, etc., etc. Let's take an example from my practice. So I saw this patient a week ago, and that patient is a typical patient diagnosed with ulcerative colitis. And I've been thinking, there are about 9,000 hours in a year. We spend 30 minutes, quality minutes in my practice, and I probably have 2 follow-up visits over the year. Conquering the 405, parking at UCLA. So from the 2 hours, it's about 30 minutes of effective time. So roughly about 1 hour of those 9,000 hours is spent on care. That's kind of a disconnected model, where we want to, basically what we want to do is basically have that connection, maintain that connection throughout the whole year, every hour when needed. So what do you require? You require pretty sophisticated health IT, I would say. But you also need to change the resistance that's currently at the provider level. You need participatory patients, and you need payers and even pharma to come into this equation. So we need to move basically from that reactive one doctor, one patient model, which is really not working. It is working in some way, you want to have one trusty person in front of you. He or she cannot manage all of those gazillion patients, so you need to move into team care or proactive care the whole day. Nowadays, we talk about that as the triple aim. The triple aim is where we want to go. We want to make sure that the health of a population is correct, that the patient has a great experience, and that we're actually spending less money. But again, 30 years ago when we started evidence-based medicine, I'm here standing with those abstract notions of triple aim. How do you get there on a Monday morning when you have a busy practice and your waiting room is just overflowing, you're still very tired from being on call all weekend? So, we have an idea. Let's take a look.
In the last decade, various healthcare reforms have led to remarkable success, lowering drug prices, introducing new technologies, and improving health plans. However, this did not prevent U.S. healthcare expenditures from exceeding $2 trillion per year. Today, more than 70% of these healthcare dollars are being spent on chronic diseases. The prognosis is grim, with more people losing access to high-quality care and coverage. So, instead of focusing on short-term cost reduction in healthcare delivery, the focus needs to shift to individual and measurable value for patients. Working together on this makes much more sense than working apart. All stakeholders should partner together and become involved to make this change, not just doctors and nurses, but all healthcare professionals, the biomedical industry, insurance companies, and the government. Most importantly, the patient will have to participate, changing from a passive health consumer to an active contributor to prevention-oriented care. The question is, how can we make this value-based healthcare possible? To pioneer this vision, UCLA has redefined patient value for a chronic disease called Inflammatory Bowel Disease by creating a value quotient, or VQ. This VQ monitors patient value over time, as well as the number of dollars spent on care. VQ represents individual patient value, defined as disease control, quality of life, and productivity at work or school. The goal is to increase individual patient value, the VQ, at increasingly lower costs over the years. The cost savings are then distributed among all participants, including the patient, who is rewarded through less costly health plans. Why would this new approach work when prior attempts to mend U.S. healthcare have failed? The difference is twofold. This involves the full participation of all stakeholders, and also the continuous integration of all scientific and technological insights into everyday patient care. This integration is achieved by a cutting-edge research infrastructure, which is built around care. Scientific progress will be translated directly back to individual patient care, resulting in better disease control and therefore improved VQs. This self-improving system is tightly controlled, and its building blocks can be adapted easily to manage other forms of chronic diseases and cancer. Improving our health system begins with fresh ideas and practical steps. The UCLA Center for Inflammatory Bowel Diseases has now begun this value-based program and invites you to participate. Please contact us today to learn more about our program.
So that's where we started 4 years ago. We started with a vision. We had some budget to make these videos, but we haven't changed our mission and our course. I want to introduce you to that model, and especially I want to focus on the performance and the scalability of the model. Basically, this model for value-based healthcare, that VQ, measures patient value over provider costs. If there's anything that you want to take home as what it is, what we're building, it's just measuring quantifiable patient value over provider cost. And we could argue about patient value, what's value for patients, but we think, well, let's start with an MS-DOS 1.0 definition of patient value. It makes sense, we're providers that want to control the disease, right? If it's diabetes or chronic heart failure or what have you. But also we want to look at quality of life, because there's more than the technical bit of healthcare. And thirdly, and I'm passionate about it, we're very passionate about introducing, to look at labor and healthcare, how to increase productivity or accelerate productivity in our patients. And provider cost, obviously we need to work smart because costs are so high. So we have to basically figure out who's at most risk for disease complications. So risk profiling is huge. Coordinated care pathways, I'm going to show you how you build coordinated care pathway, how you Lego coordinated care pathway in a way. And furthermore, I'm going to show you that task differentiation in chronic disease management is really where we should go and where these apps can help. So what we, at the end of the day, want to achieve is to bring all of that into one platform. Patients as so-called end users, providers, and payers working jointly together. And what we're now starting to do, hopefully we'll start that this year, is to come under shared risk profile. So we can, as providers, we can assume part of that risk again. And I think that's a great step forward in trying to control cost. So let's look at that triple aim. How would that VQ model actually be translated into the triple aim? Well, very simply, patient experience. We just heard that patient experience and patient apps, and also at CES is fantastic. Dashboards on their apps, they can participate. There's education there. There's all sorts of training. Show you some wellness programs we integrated. And so showing also health outcomes really is aiming at the health of our population. On the provider side, it obviously, we need to really improve our act with decision support for our providers. That's I think, that's currently lacking in the systems that we're using. Changing the stakeholders is what's happening currently. Where I was as a physician at the top of the pyramid, overseeing and owning basically the healthcare delivery, it shifted largely to a co-ownership today with payers. But in the future, and that's where this symposium will aim at, it's all in the hands of the consumer. You're buying iPhones, you have the power, the processing power of all that data. Yesterday at CES, the wellness and the health and wellness section in CES exploded, and there are so many very attractive apps out there. This is a very old slide, so almost 3, I'm ashamed to say, but at that time, almost 50,000 health and fitness apps were actually in those stores. And I'm showing it because 1/3 of those apps is actually already being used by providers. And I'm sure that this slide should be updated. I don't have the data to be updated for where we are today. So let's take a look at that prototype. We started almost as a going rogue group here at UCLA because Care Connect was not there yet. There were all sorts of systems out there. We said, well, let's build it as a standalone. We basically build out our apps in the iOS and in Google Play. This is basically the user interfaces. You can actually download it now from the app. And you can see that patient value is really measuring disease control or the inverse of disease activity. We use kind of really validated indexes to do that. And there are all sorts of indexes looking at, for instance, IBD that tell you about what are great health outcomes. Don't forget that when we are basically looking at new interventions or new drugs, we have to do all sorts of trials. So take all those indexes back into these equations makes a lot of sense. We obviously have to validate if this index worked, and we recently published that as well. Quality of life you can make it very quantifiable as well as productivity. There are indexes to do so. So basically you can have that equation quantified on your app, on the health outcomes of patients. Don't forget, you have to participate as a patient. So our MS-DOS 1.0 definition of participation was showing up for clinic visits, doing your lab visits timely, be interactive to tell us how you're doing. So we push that out and they tell us in those validated indexes how they're doing regularly. Doing e-learning, we called it My Academy. That's a mandatory annual session to do as a patient in order to train yourself about your disease and your current status, as well as a couple of wellness programs I will show you later. Now we're at the next release. We're happy to work with the UCLA teams to even see if we can get it into Epic, and I'll have a slide on that as well. But we introduced many additional features. Again, this is for the first disease where we started, and I'll show you a little bit later what other diseases are on our radar. There's a thing called telewound monitoring. We even work with our surgeons because IBD sometimes requires surgery, so we have these. It's really fun in our first pilot study that we actually were able to see an abscess formation in a wound appear on a photo. Can you believe it? So we kind of hope to avoid any ER visits. Anyway, there's a lot of functionality now in these apps, and patients love it. We develop them with our patients. Those are called focus groups, so they tell us what they like and what they need. But let's take the next step. Let's do a little bit of, let's look under the hood. Because what you have to offer in these apps cannot be simply, there must be multiple dimensions to care, because care truly, especially for chronic diseases, is pretty complex. So how do you construct the coordinated care pathway that drives these apps? Well, this is to show you that it's not that difficult to imagine. I mean, a care pathway is something of a time axis and something of all sorts of required mandatory activities in terms for monitoring of health outcomes or monitoring safe side effects from, for instance, drugs. So what you do is you invite UCLA champions to the table. We sit behind whiteboard. Actually, we're building an authoring tool now to do a wizard like it. But basically, you take all the literature, all the evidence that's out there, and you're creating those default care pathways. Once you do that, you go to the next level. You say, well, who needs to do that? Lab monitoring, do I need to do that? I'm a little bit too expensive to do lab monitoring, okay? So we train our RMs, or our medical admin, to look at and triage for lab monitoring. We do instruction, we do all sorts of education stuff that I not necessarily as a provider need to do. Let me just stick to governance and the technical bits that, that is required for this type of healthcare. Most importantly, patients will have a large chunk of work to do. When you have an app on the phone and you can do data entry, or you can sense your biometrics, or whatever you want to do, a patient becomes really a very key stakeholder in their own care. I hope that makes sense. And the app basically reflects what patients can do, what part of the care pathway is owned by them. So in short, we're tracking outcomes and cost. Remember the VQ, patient value over provider costs. And now we have an attractive model to track relevant patient-reported outcomes, or PROs. And we can actually continuously, 24/7, correlate that with the accepted, validated clinical scores. And now, for the first time, you can take these individual segments of those care pathways and put a dollar amount on it. Okay, so this is now directly tracking costs. For providers, you're able to really give them more than can be extracted from current EMRs, because you give a lot more decision support on patient level as well as population level. And they can benchmark it to the colleagues, to other providers in California, to however you want to benchmark it. For my academy, we really build modules around how these programs work, around diagnosis, around management. They get points. We kind of gamify those user interfaces a little bit. And there are annual updates that they need to go through, and we kind of make them feel very happy about their achievements. More importantly, on the backside, we talk to payers and say, hey, reward these patients. So there's a dent at 80%. So 80% or more of that type of work is being rewarded. Take away copay or reduce premiums. We're in California. So I'm Dutch, by the way. So I'm only here like a couple of years, but wellness is huge in California. So let's build those wellness programs. These are 6 weeks. We don't throw an app at our patients. These are 6 wellness programs where care coordinators work and interact with our patients. So what do we have? We have My Coach, which is a mental support program. For My Coach, we started with behavior activation therapy, and now we're moving into CBT, stress, motivation, and addiction. All 6-week programs integrated in the care pathway. Nutrition is hugely important. I'm a GI guy, so we build 6-week programs around, how can we fool or trick or change the microbiome in order to have an effect on health. And that's a huge topic at the moment. My acupressure, we developed that with the UCLA East-West Medicine department. We have My Fitness, where we hope to work with Equinox here to further these programs. We have My Yoga and My Meditation. So having all of that, we really looked at Dr. Pfeffer, and we started to work with Dieter Kies, who is here. And we went on a journey, because we're launching Care Connect, and that's a lot of work, most of you know that. So how can we take this standalone thing and move that into our EMR? We're currently basically on a roadmap of doing that. 5 steps, I'm not going to go into the details, but I'm just going to run this animation to show you how complicated that actually is, because there are so many things that you need to find out and stay compliant, be safe, all of that stuff around security. But I'm happy to say that we're moving to the right side in an accelerated way. I'm very happy. I hope that next year, or this year, actually in 2016, we will be living in a My Chart environment, a patient-facing application of the UCLA. So let's quickly look at some performance now, because we're still at UCLA, and how do we perform? How do we change patient value? How do we reduce cost? And how do we scale up so that it means something at the end of the day? So basically, those are technical slide showing you that these are, for inflammatory bowel disease, some very worthy health outcomes. Here you see that the disease is basically, we can track disease activity, we can track disease control very meaningfully from the app. This is to show you that even if, there's a big change in folks using the apps versus folks that don't use these apps. So the more compliant you are, the more your quality of life actually accelerates. This is to show you that even, again, between low compliers at the 20% compliant versus the very compliant patients, it takes 6 weeks, for them. We are 6 weeks more effective to get patients into full control. And in those 6 weeks, looking at the low compliers, they will visit ERs, they will be hospitalized, their surgeries, all of that stuff. So these type of app care delivery really works. The more, and we are over 1,500 patients now in that IBD environment, the more time you spend in these programs, the more they're patient value, so the numerator is actually increasing. Let's look at some of the cost. Well, this is some of the initial data, and if you notice, this slide is different from the previous, because now there's Anthem in there. In 2012, we contracted with Anthem because we as researchers, we're kind of very proud of the things we do, and we have our Excel files, and we publish it, etc., etc. But in a real-life demonstration model, we'd love to show the effect on the payer side. So we said, Anthem, would you like to look at our UCLA program and see if we're performing well? So everything I'm going to show you is Anthem data, not my data. It's shown into Anthem members diagnosed with this form of chronic illness. And you see the program performs excellent. This care pathway modeling, remember that first slide, moving from symptom-oriented to prevention-oriented care, introduce biomarkers and all of that stuff in those care pathways on those apps. And you see how it pays off. On the, we have a growth of 344% here of a fecal marker actually that can be tested at home. And you see how that is correlated with taking down those big bucket numbers, hospitalization, surgeries, etc. So, long story short, put a single patient on a matrix of low to high value and high to low cost, you want to see some kind of vector analysis of folks. You could have bad genes, so some folks behave very differently from folks that have a mild form of disease. But overall, annually, you're able to analyze those cycles and see those clouds moving into the right direction. We actually save money. This is to show you, this is for the Anthem population in California. They have 38,000 members diagnosed with IBD. And let's just do a projection in 10,000 patients. If we run this program for a few years, there's a $42 million of cost reduction here. And I told you this is shared savings, and I've shown you the curves at UCLA. So this is another idea how, as a health system, you can actually basically make some money. So this is all very, very exciting. And I have to say that I'm extremely excited by the way that we're actually going to do this in California. There's luckily a lot of support from our regions in California. So across the UC system, we want to start working not only with IBD, but actually we work now with a number of champions here at UCLA in all those different disease areas. There's a small typo. But I have to say that Anthem said, well, take the first 20 big bucket items of cost, like chronic heart failure, low back pain is actually the one that we're trying to launch now, then it makes sense. So this gives you an idea of how we can actually scale across our UC system in California. And with that, I think I'm 1 minute over my time. Thank you so much for your attention.
Thanks, Dr. Hommes. Very, very amazing stuff. And we're very excited to be able to partner with him to really automate the back end of this so that there's integration between electronic health record and these amazing applications.